Now, in this case, our patient is 64 years old. So what role does age play in the decisions for treating patients with MKIs who have iodine refractory DTC? Marcia Bros did an analysis of the patients from the SELECT trial based on their age. The age cutoff was 65 years old. So in patients who were 65, who were older than 65, the older patient population, did they benefit from lenvatinib compared to younger patients? And indeed, what was perhaps somewhat surprising was that there is a benefit in terms of response rate, and patients who are older also have progression-free survival benefits. But what was surprising was that the older patients who were older than 65 years old actually had an overall survival benefit when they were randomized initially to lenvatinib compared to placebo. Again, it's important to remember that this was a crossover trial, so that the patients initially enrolled on placebo crossed over to active therapy when they had disease progression. So nearly all patients received lenvatinib on the treatment. So the question is, lenvatinib earlier versus later? And again, we saw an overall survival benefit with the older patients who initially were treated with lenvatinib compared to those that were initially treated with placebo. So I think what we know from these data are that we don't want to withhold lenvatinib based solely on age. Patients, even who are older, will perhaps have an overall survival benefit. And is this practice changing? I think for me, it was because of the side effect profile with lenvatinib. The older patient population may not fare as well in terms of the side effects. So it is a more challenging decision to consider the risk-benefit ratio in the older patient population who may have more difficulty with side effects. But when there's an overall survival benefit, it's really important to think about use of therapy in the appropriate patients who are going to be able to tolerate the therapy with appropriate management of their side effects. One thing that patients often ask me is, what is it going to be like on lenvatinib, and how long am I going to be on it? So in terms of the most common side effects that we see, hypertension is one of them. We see hypertension frequently in these patients. The onset can be very early, even after a matter of just a couple of days. So it's important to manage hypertension carefully. We also know that patients who do develop treatment-emergent hypertension actually have an overall survival benefit compared to those who don't. So when patients do develop hypertension, you don't want to just stop lenvatinib, but you want to manage the hypertension because it's a pharmacodynamic marker of benefit from the therapy. Patients also often will have fatigue. They have some diarrhea, anorexia, occasionally nausea. All of these side effects, again, need to be managed very actively in order to be able to keep patients on therapy. So we take advantage of our dietitians, and we take advantage of other supportive medications to keep people feeling as well as possible. Occasionally, dose holds and dose reductions are definitely necessary in managing patients on lenvatinib. And one thing that we've learned from looking at the data is that you don't want to hold the therapy for too long because when patients had dose holds of longer than 10% of the time that they were on the therapy, they didn't do as well in terms of progression-free survival and response rate. The half-life of lenvatinib is short. Patients often feel better very quickly, so we try to keep our dose holds down to just a couple of days. Many times after patients recover from the side effect that prompted the dose hold, they do need to have a dose reduction. However, sometimes patients can resume the prior dose that they were on as well. Another question that patients often ask is, do I have opportunities for other therapies? And we do know, particularly from real world data, that when patients have been on other MKIs, such as sorafenib, for iodine refractory DTC, and then progress, We do see activity with second-line lenvatinib. So patients in Korea who were studied who received second-line lenvatinib had an overall response rate of 20%. So not quite as good as the first-line overall response rate, but still better than nothing. And those patients who did go on to receive second-line lenvatinib did have an overall survival benefit compared to those patients who did not receive the second-line lenvatinib. Now, those patients may not have received second-line lenvatinib because they were too sick to receive second-line therapy. So we can't say that we know that there's an overall survival benefit with lenvatinib compared to placebo in the second-line setting. But we do know that those patients in the real-world setting did survive longer with second-line lenvatinib.